Okay, so now that we have an understanding of how to test hearing and how to diagnose hearing loss, we're going to talk about different disorders of the outer ear, the middle ear, the inner ear, and beyond. So first we're going to talk about disorders of the outer ear. If we remember, the role of the outer ear is to collect sound. The pinna funnels sound in, transfers it through the ear canal to the tympanic membrane. Disorders of the outer ear are conductive hearing losses, and they're not as severe as, say, a hearing loss in the cochlea. So anatomy, some review, is the body structure. Physiology is the body function. Sound transfer is a very complicated and impressive process. So we start with acoustical waves in the air. You might remember from hearing science, we have longitudinal waves where particles move from compression to rarefaction to compression, rarefaction, and this wave of energy is sent through. So the wave of energy is collected by the two pinnas, transferred through the ear canal. Once it touches on the tympanic membrane, a mechanical reaction begins. So the tympanic membrane starts the movement of the bones of the middle ear. Then the bones of the middle ear end up pushing on the cochlea, which is filled with fluid, and we have a hydraulic action as the fluid in the cochlea moves. The fluid in the cochlea then touches on the outer hair cells, and it triggers a chemical reaction. The chemical reaction signals to the auditory nerve that it's time to fire, and impulses are sent up the auditory cortex. So we start with the acoustical energy, the acoustical waves collected by the pinna in the ear canal. So the outer ear, the auricle, is the most noticeable portion of it. It varies from person to person in size and shape. If you look at your ear, it's a funnel-like position, and it gathers sound waves from the environment. It's made entirely of cartilage, twists and turns, and it's shaped that way for a reason. And we have two ears for a reason, and they are facing forward for a reason. So the idea behind these two ears with their cartilage and their twists and their turns is that they're going to collect sounds best that are coming at us as opposed to behind us. So the idea, was that sounds coming in front of us are more important than sounds coming from behind us. And having these two ears helps with localization. So if a sound wave hits the right ear before it hits the left ear, that means that the sound is coming from the right side of us, as opposed to if a sound hits from the left ear. We know the sound is stronger on the left side, it's therefore coming from the left side. The middle portion of your pinna is called your concha, and that helps funnel sound into your external auditory canal. That's also known as your ear canal or your external auditory meatus. Like I said before, two ears and the shape of those two ears is very important for localization. Localization is identifying where the sound is coming from. You have this little protrusion in your concha called your tragus, and if I wish I could demonstrate, but I can't. But if you push that tragus in, it's almost like it fits into the whole of your concha, and that's the best way to block loud sounds. So if you're on the subway platform and a loud sound is coming, you don't put your finger in your ear. If you really want to block the sound, you just push that tragus in, and that's the most effective way of blocking sounds. And some animals can actually close that off on their own. Now, the shape of the auricle and in fact the shape of the ear canal are more efficient at delivering high frequency sounds than low frequency sounds. And why might that be? Why is it important that we hear high frequency sounds over low frequency sounds? Well, high frequency sounds have those important speech sounds to them. Low frequency sounds tend to be noise, and noise isn't important for our hearing. In fact, noise can mask our ability to hear. So our auricles and our ear canals are shaped to better transfer high frequency speech sounds to the tympanic membrane than low frequency sounds. Okay, so can everybody see this picture? So we've got our auricle here, and then here's our external auditory meatus, or our ear canal. And if you notice, it's shaped on an angle. It's like an S-shaped curve. And why do you think it's shaped like this? For the same reason that the pinna is shaped like this, to better transfer high frequency sounds than low frequency sounds. Now you have an outer portion of your ear canal, which is made entirely of cartilage. And then you've got the inner portion of your ear canal, which is bone, okay? So this outer portion is where we have hair cells and where we have cerumen, which is also known as wax. Back down at the end of your ear canal, you have your eardrum or your tympanic membrane that is protected and kept warm and safe at the end of the ear canal. If you were to ever use a Q-tip and you push the wax from here into here, then you're in trouble. Once something enters the bony portion of the ear canal, it hurts, and it would have to get removed by a doctor. Okay, so when you use Q-tips, you're not even supposed to use Q-tips. It's not recommended. But if you were to try to dry out your ears, you want to stick to the outer portion, to the cartilaginous portion of your ear canal. Okay, so the external auditory canal, that's what we just saw. It's also called the external auditory meatus. It begins at the concha, it extends inward and slightly upward. It's approximately an inch long, elliptical in shape, lined entirely with skin. The outer portion is cartilage. In that outer portion, there are several glands. You have glands that produce earwax. And earwax exists naturally on its own when you chew, when you talk. If you have a moment, lift up your jaw, move your jaw around. When you're moving your jaw around, what you're actually doing is you are loosening up the wax and it comes out on its own. So you see this portion over here? As you talk, as you chew, as you move, this part of your ear canal moves where the earwax is produced, and that helps move the wax along. So the wax comes out naturally on its own when you're sleeping, just, in everyday life. You shouldn't necessarily need to use Q-tips because it comes out naturally on its own. But let's say you're older. Sometimes people who are older, they tend to accumulate earwax, and when earwax gets accumulated, that's when it becomes dark and harder and more difficult to remove. There are also hair cells present along with the cerumen, and the idea behind having hair cells and wax was to keep foreign objects, for example, insects, from entering the more protected portion of the ear canal. So oops. Okay. Sorry, I'm skipping around. My computer's being funny. All right, so over here we have our wax and our hair cells. No wax or hair cells in here. This is the most important part of your ear canal, this tympanic membrane. The idea was that wax and hair cells protect, they kind of make it a not pleasant environment so that insects don't get further in here. And I know it sounds gross, but think thousands of years ago. Back here is a warm, dark, moist environment, so it would be like conducive for insects. So our bodies wanted to make that area less conducive for insects, which is why there are hair cells and there is earwax. Okay, so infants and children, their ear canals are on a different angle. They're angled more downward, so if you were to look into a child's ear, you pull it up farther. So in general, you remember that picture, it's on an angle. So to look into a person's ear, you pull the ear back and up and you straighten it out. You straighten out that S-curve and you could get a clearer image of the tympanic membrane. So you might have heard of TMJ. That's where your jaw hurts, your mandible hurts, it overrides your jaw, it pushes, it causes pain, and the pain is perceived in the ear, but really it has nothing to do with the ear. It's just sort of that portion. If everyone were to open their jaw very wide right now, you would see your jaw pushes on your ear canal, and that's, if you have jaw pain, that might be perceived as pain in the ear, but it really has nothing to do with the ear. So that's TMJ syndrome. You might have myofacial pain dysfunction, which is, again, pain perceived in the ear, in addition to headaches, dizziness, back or shoulder pain. And again, that could be brought on by emotional stress or tension, but it has nothing to do with hearing. Okay, so your external auditory canal, it terminates at the tympanic membrane. So the end of the external auditory canal is the tympanic membrane, and it's kept protected and at a constant temperature. Just like the pinna, the ear canal acts as a filter to reduce low-frequency sounds, and a resonator, so an amplifier, if you remember that from hearing science, a resonator between 2,000 and 7,000 hertz. And what important things happen between 2,000 and 7,000 hertz? Our speech sounds. So the ear canal is an efficient transfer of energy from the outside to the tympanic membrane and the middle ear space. It is shaped like an S for a reason, because it resonates, it boosts sounds between 2,000 and 7,000 hertz, which are important for speech. Okay, so at the end of the ear canal is this concave disc-like structure, the tympanic membrane, also known as the eardrum. It is the border between the outer ear and the middle ear. And when you look through an otoscope, you can see it. So if you ever get the opportunity to do an audiology practicum, you'll be able to use an otoscope and actually see a tympanic membrane. There are 3 layers to that tympanic membrane. The first layer is just a continuation of the skin of the ear canal. The second layer is a fibrous connective tissue. It's tough, and that's what helps vibrate, and that's the real vibration portion of it. And the third layer of the tympanic membrane is the lining of the middle ear space. The lining of the middle ear space is very similar to the lining of your nose. So it's lined with mucous membrane. The tympanic membrane is extremely thin, and it is an efficient vibrating system. It's very rich in blood, and when you get infected, it comes red. I remember when I was a child, I had an ear infection, and the doctor said to me, "Your ear is as red as that box over there, the medical waste box," because it hurt so much. It was infected. It was bright red. So this usual translucent gray tympanic membrane gets bright red with blood when you have an ear infection. So here's what a tympanic membrane looks like. See, it's supposed to be clear. It's a little gray. This is the malleus, the first bone of the tympanic membrane. You can see it. Okay, so embedded within the tympanic membrane is the first bone, the largest bone of the middle ear, the malleus. And the tip of the malleus is the centermost portion over here. This is called the umbo, and this is what it pulls the tympanic membrane up. And it is the point of greatest retraction. It makes it concave. So do you see how the tympanic membrane is on an angle? Here's the malleus, the incus, and the stapes. Combined, these 3 bones are known as the ossicles. The malleus is embedded in the tympanic membrane, and the point of greatest contraction where it's pulled up is the umbo, okay? And again, it's on an angle for a reason. Our body, everything in our body seems to have a reason. So the malleus in the tympanic membrane is the first mobile link in a chain of auditory events. This pressure wave causes the tympanic membrane to vibrate, and it produces the same spectrums of sounds from the ear canal. So the tympanic membrane is going to vibrate differently based on a low frequency sound or a high frequency sound, and it's going to vibrate with a different intensity depending on whether it's a soft sound or a loud sound. So the tympanic membrane takes this acoustic energy. The waves bounce off the tympanic membrane just like an eardrum, right? A drum. And it sets this chain of movement through our middle ear. Here's an example of an otoscope. If you were to look through someone's ear, you pull the pinna back, you send the light in, and you can see this tympanic membrane. So hearing loss in the outer ear. Conditions that occur to interfere or block with normal sound vibrations are called conductive hearing losses in our outer ear. Conductive hearing losses are rarely severe. They never exceed a 60 dB airborne gap. So regardless of how bad the conductive hearing loss, the cochlea that main hearing organ is not going to be overly affected. So basically, if you had the choice between an outer ear pathology or an inner ear pathology, you want an outer ear pathology because it's never going to end up that severe. And the only thing you need to do if you have an outer ear or a middle ear pathology is amplify the sound to overcome that loss. Once you can get the sound into the cochlea, everything's a go. It's just overcoming that loss. But the cochlea, the hearing organ, is still able to transfer the sound. In regards to development of our outer ear, 28 days after conception, you have these bulges that appear to develop in the head and the neck, and then there are arches and clefts in them, and they turn into our organs. So we have outer layers, an inner layer, a middle layer. Each contains an artery, cartilage, muscle, and a nerve. The auricle, by the second fetal month, the tragus, the helix. I'm not going to ask you any of these questions, but about 20 weeks, by 20 weeks, the cochlea is ready to go. You can hear. Well, the fetus can hear. You know, it's in fluid and whatnot, so it's not hearing perfectly, but the systems are a go. Okay. Okay, so remember I said a hearing loss in the outer ear produces a conductive hearing loss, and it's rarely severe. And not all abnormalities of the external ear necessarily cause a hearing loss. There could be disorders of the auricle, so the entire auricle may be removed. For example, an accident, a car accident, or burn, surgery, cancer. So you could have no auricle. There could be microtia. This is a genetic disorder where one ear or both ears are very small in size. Anotia, where there's absolutely no auricle at all. You could have congenital malformations, are sometimes associated with Down syndrome. This is a picture of microtia. So you see how the ear is very small in size. It's not fully developed. Now this person probably has normal hearing. It just looks different. Treatment for this includes otoplasty or pinnoplasty, so basically plastic surgery to make the ear look more normal, but it's not done on children because they're not fully grown. So you might use a prosthetic for, if the child feels more comfortable wearing that, and wait to hold off on surgery until the child is older. Here is Anotia. There is no pinna. So this child was born with no pinna. There's just, you see, an opening to the ear canal. There's also Atresia, where either the cartilaginous portion or the bony portion of the ear canal never formed. So this could be in isolation or with other abnormalities. It may occur in Treacher's-Collins syndrome, which is a congenital disorder involving the facial bones, the cheek, the lower jaw. If the abnormalities are also in the middle ear, surgical correction is difficult. It could also be caused by blood blisters, frostbite, trauma. So, see in Atresia, there's not even opening to the ear canal. And it's not as simple as, drilling a hole. You can see over here in the middle ear is also malformed. So for Atresia, a person that has Atresia, the best option would be a bone-anchored hearing aid, which we'll talk about in a few chapters, that basically skips this area that's not working and directly stimulates the cochlea. Stenosis is a narrowing of the ear canal. Some people just have very narrow ear canals. In this case, it doesn't necessarily, again, cause a hearing loss, but the issue may be wax may build up because the ear canals are so small and narrow. So a person that has stenosis would have to get their ears cleaned more regularly. Like I said, yes, it doesn't necessarily produce a hearing loss, depending on the occlusion of wax, but that can be taken care of. collapsing ear canals. We spoke about this a little bit. This isn't really a condition. This is just something you should be aware of when you're testing someone for hearing loss. This is if you put very heavy supraoral earphones on a child and they like weigh the child's ear canal down and it kind of smushes the ear canal and it creates a false conductive hearing loss. This also happens in older adults where it just sort of gets smushed. So the best way to avoid this is to use insert earphones. Foreign body. Sometimes kids place things in their ears. Who knows why? You know, my nephew placed corn in his ear. He was like 5 years old. He shouldn't have been putting corn in his ears. Too old for that, but he still did. And my sister had to take him to the doctor to get it removed. A old professor of mine told a story how one day, you know, she was driving somewhere and she had her daughter in the back seat and her daughter was in a car seat. She was probably like 2 years old and it looks like there was like red coming out of her ear and the woman got all upset and she rushed her daughter to the doctor or the hospital and it turns out that the daughter had put a red M&M in her ear. So for some reason, kids might put things in their ears and like I said, if you get past that cartilage portion and get stuck in the bony portion, it hurts, it causes pain, it could get infected, so you have to get it removed. External otitis, maybe some of you have had this. It is an infection that occurs in the skin of the ear canal. So external means outer, otitis means ear. External otitis, also known as swimmer's ear, is an infection in the skin of the ear canal. It usually develops when people have water traps in their ears. So people that swim a lot, they get water in their ears, it gets stuck. The water gets infected. A person would complain of itching or pain as it becomes a bacterial infection. So it could originate from earplugs, hearing aids, soap. The area becomes red, swollen, a discharge. You certainly can't test these people hearing because it hurts too much. So here's a picture of external otitis. It is treated by irrigating the canal with warm salt water, drying it, and applying antibiotics. Myringitis is an inflammation of the tympanic membrane in response to a viral infection. This is very, very serious. So look at this tympanic membrane over here. Look at how inflamed it is. Fever, pain, blood blisters. Some forms are dangerous and require aggressive therapy, especially in diabetic or elderly patients. Bone destruction, spread of infection could be fatal. Your ear is adjacent to your brain. Any infection in the ear needs to be monitored very closely as it could easily travel to the brain. There could be growths in the ear canal, little benign, mostly benign tumors called osteotomas. They don't present a problem unless the ear is occluded. A conductive hearing loss could result. I had another professor that had this. He had osteotomas. He was probably in his mid-60s, and he loved, swimming in the ocean. He was always in cold water, always in the ocean, and he's just started developing these little growths in his ear, I guess as a function of always being in cold water. They were not a problem in his hearing as they were just tiny. They weren't including anything. Sometimes they might grow outward. That would be exotosis. And again, you would remove them depending on, how they look or if they block anything. Cerumen, earwax, so produced in that outer portion of the ear canal. Excessive wax could lead to a conductive hearing loss, but it has to be excessive. So the wax would need to be impacted. When I say impacted, I mean it is completely occluding the ear canal. So if the wax is completely occluding the ear canal, then you could have a conductive hearing loss. But if a portion of the ear canal is still open, it's not going to create a hearing loss. Like I said, if you push that wax too far into your ear canal, if it starts to hurt, that means it's entered the bony portion of the canal and it needs to be removed by a doctor, suctioned out or flushed out. There is some medicine that softens the wax because hard wax, dried wax is difficult to remove. So, for example, let's say you have occluded wax that you pushed into your ear canal and it's like stuck there, it's been there a while, now it's hard, it's almost like it becomes like a scab. You know how when it hurts when a scab comes off? Getting this sort of wax, this brown hard wax out would hurt. It would feel like you were pulling scab out. So there are drops that a person could use the week before the wax is removed to prevent it from hurting. So the drops would sort of soften it up. I really don't know much about ear candling. It seems kind of ridiculous to me. I don't think you have any need for it, and I don't know why you would want to put like fire near your ear. Wax comes out on its own, right? So another disorder is a perforation of the tympanic membrane, and I don't know if any of you guys have had this, but if you have, I think it is incredibly painful. So there are two ways that it could happen. It could happen from the outside going in. For example, if you have a Q-tip or a pointed object in your ear and it punctures the tympanic membrane from the outer ear canal in, or if you have an ear infection in your middle ear that has gone untreated and it keeps building and building and building. The excessive pressure in the middle ear might burst the tympanic membrane outward to release the pressure. Okay, both are, very painful things to happen. The amount of hearing loss produced by a perforated tympanic membrane depends on several variables, including its size and the place of perforation. So if it's a big hole in the center of your tympanic membrane, yes, you're going to have a hearing loss. If it's a tiny hole towards the bottom or the outer edges of your tympanic membrane that can heal on its own, it won't necessarily cause a hearing loss. So perforating your tympanic membrane is very painful. The traumatic perforations could alter essentially normal tissue. So sometimes, for the most part, if the hole isn't that big, it will heal on its own. So just like if you cut yourself, your skin will heal on its own, but it might heal like with a scab, it might heal with rougher skin and fiber or tougher skin. And that could affect your hearing because this tympanic membrane, this very thin, efficient, vibrating membrane, if it has scar tissue on it, scar tissue isn't going to work as well as the original tissue. This is a picture of a very big hole in the tympanic membrane, and I'm sure it is very painful for this person. I can't even look at it for that long. It must hurt so much. So with a hole that big, you could do Myringoplasty, so a surgical repair of it, in which case there'd be a graft of skin. So vein grafts are used, or the muscle fascia, I don't think I pronounced that correctly, that part of that skin that's on top of your muscles, because it's a bit more fibrous. It's not as loose as a typical top layer of skin. So you could do a skin graft over the hole, right? So there they are placing the skin over the hole just to help support the hole healing. Like I said, if it were a much smaller perforation, it would heal spontaneously. But for a large perforation, a doctor might do a Myringoplasty on the skin. So thickening of the tympanic membrane could also cause a hearing loss. So in response to infection, usually of the middle ear, the tympanic membrane becomes thickened or scarred, and this is called tympanosclerosis. The thickening interferes with the vibration of the tympanic membrane. It could cause a hearing loss. It doesn't respond well to medical or surgical treatment. So if a child's had lots of ear infections and lots of PE tubes, they could get tympanosclerosis, which would be a thickening of the tympanic membrane, and it just doesn't work as well as it had originally. So here we go. Do you see over here this skin? This is the tympanosclerosis. It's not as clear and thin. This looks like a hole, so I don't know if they had a hole over here and then tried to heal on its own, and you have the thickened skin over there, but it's not as clear and, not what it had been. Okay, great. Thank you.